Greetings from National Academy of Medical Sciences, India. Focusing on NAMS Vision 2030, NAMS is pleased to share some of the important activities like NAMS National, International Fellowship and Membership, Member After Day AIIMS-PGIMER-NAMS, NAMS Task Forces, AIIMS-NAMS Navigate Medico CME activities, publication of annals, newsletter, networking with professionals, public orations, Young Scientist Fellowship, Scientist Exchange Program, scientific visit of Emeritus Professor and many more activities. All application forms for fellowship, membership, associate fellowship, and member after day NB have been made online and objective criteria from the year 2022. NAMS has also started a new online AIIMS-NAMS Navigate CME and Navigate Medico CME program to assist in the development of competencies among PG students and share multimedia learning resource materials as e-library. NAMS has also started 21 task forces to address medical issues of national importance. Under publication activities, NAMS has its own annal as Annal of the National Academy of Medical Sciences. In addition, NAMS also publishes its quarterly NAMS newsletter. For more details of NAMS activities, please visit our NAMS website www.nams-india.in or scan QR codes with the camera app. Greetings from National Academy of Medical Sciences, India. Focusing on NAMS Vision 2030, NAMS is pleased to share some of the important activities like NAMS National, International Fellowship and Membership, Member After Day AIIMS-PGIMER-NAMS, NAMS Task Forces, AIIMS-NAMS Navigate Medico CME activities, publication of annals, newsletter, networking with professionals, public orations, Young Scientist Fellowship, Scientist Exchange Program, scientific visit of Emeritus Professor and many more activities. All application forms for fellowship, membership, associate fellowship, and member after day NB have been made online and objective criteria from the year 2022. AIIMS has also started a new online AIIMS-NAMS Navigate CME and Navigate Medico to assist in the development of competencies among PG students and share multimedia learning resource materials as e-library. NAMS has also started 21 task forces to address medical issues of national importance. Under publication activities, NAMS has its own annal as Annal of the National Academy of Medical Sciences. In addition, NAMS also publishes its quarterly NAMS newsletter. For more details of NAMS activities, please visit our NAMS website www.nams-india.in or scan QR codes with the camera app.
हाँ भाई क्या हुआ?
पूछ रहे हैं डॉक्टर जसवंत सर. डॉक्टर जसवंत प्लीज.
Yes, I'm just joining in a minute.
Okay sir. Okay.
वेट कर लिया?
Hello and good afternoon, everyone. Welcome to the NAMS next NAMS AIIMS-PGIMER Navigate Medico CME program, and I apologize for the delay due to traffic issues. So, sorry, sir. So, to begin with the session, I would like to request Professor Umesh Kapil, sir, for the welcome address for today's speaker. Over to you, sir.
Good afternoon and namaskar to all of you. First of all, my thanks to our respected speaker, Dr. Aman Sharma, who is a professor of medicine and an eminent scientist working in the field of vasculitis. I must say that it's a privilege and honor to have Dr. Aman Sharma with us to make a presentation on this important topic. We started this Navigate program with the aim of providing continued medical education to all the postgraduates, young faculty members in different institutions of the country. Also, the doctors are working in the primary, secondary level also, and tertiary level also, because there are limited opportunities for them to have the continued medical education session. So, what National Academy of Medical Sciences did about 2 years back, that we started with the collaboration of All India Institute of Medical Sciences and PGI. We started Navigate program. We are just trying to navigate the postgraduates so that they're able to update their knowledge. Apart from this, there's an important issue which country is facing right now, is that we have about 120,000 MBBS students who pass out and they appear for the NEET. And we have only 20,000 seats, and remaining, again, they try to appear for the NEET examination. So there's no system by which their knowledge can be updated and they can be successful in the NEET examination. So what NAMS has done, has identified the most eminent faculty from different colleges, AIIMS, PGI, and then we request them to deliver a lecture on 1st and 3rd Friday. This is from 3 to 5 o'clock. And this session is followed by a question answer session, which is extremely useful for all the participants. Once again, I welcome you on behalf of National Academy of Medical Sciences to this important Navigate session. And I hope that all of you are going to enjoy this session. Please ask as many questions as possible, because these questions are always helpful to update the knowledge of everybody. So please, with these few words, I'll stop over here and I hand over to Dr. Jaswant, who is an assistant professor in psychiatry at AIIMS New Delhi, to take the proceedings further. Over to you, Jaswant. Thank you.
Thank you very much, sir. Thank you for the kind welcome. And now I would like to request Mr. Raviji to please play a message from Professor Digambar Behra, sir, the President of National Academy of Medical Sciences.
My dear young colleagues, faculty, and officials of the National Academy of Medical Sciences, a very good afternoon to all of you. With immense pleasure, I invite you all to this program. National Academy of Medical Sciences, that is NAMS India, it was established on the 21st April of 1961 with the objectives of promoting the growth of medical sciences. It was inaugurated at New Delhi on 19th December 1961 by Pandit Jawaharlal Nehru, the first Prime Minister of India. The NAMS fosters and utilizes the academic excellence of health professionals in the country as its resource to promote excellence in medical education and skill development in the field of medicine and allied sciences. The Government of India has recognized the Academy as a nodal agency for promoting continuing medical education for medical and allied health professionals and is advising the Government of India on several matters of national health policy and planning. The best in the field of medicine are part of this umbrella organization, and who is who of medical science guide the NAMS. The National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia, and workshops in basic sciences and applied clinical disciplines. The aim of the National Virtual Postgraduate Medical CME is to facilitate the postgraduate students and young faculty members to increase their knowledge in the medical subjects, to navigate them to be more proficient in their profession and pass their NEET and PG examination to become better doctors, eminent biomedical scientists, teachers, and researchers. As a part of this responsibility, NAMS, in collaboration with the AIIMS New Delhi and 16 other AIIMS-like institutions of the country, has initiated this navigation program in the form of dialectical lectures and discussions. The program is regularly held every first Friday of the month at 3 p.m. The best and useful topics are carefully chosen, and the best teachers from various AIIMS are picked up to prepare and give these lectures. I am sure you all will enjoy these talks and will like them and found them useful in your future lives. Thank you.
Thank you. So next, we'll listen to the message from Professor M. Srinivas. He is the Director of All India Institute of Medical Sciences, New Delhi. So I would request Mr. VZ to please play it.
Namaskar. At the outset, I congratulate the team behind the NAMS Navigate CME program. Providing quality of education to our postgraduate students is one of the prime responsibilities of AIIMS. I know that our able faculty is leaving no stone unturned in achieving this mission. However, there always remains a scope for improvement. Through this unique initiative, there is an opportunity for our postgraduate students to learn from the experts in their field. This learning will go beyond the boundaries of department where our postgraduate students are working and will also bring in more flavor in their knowledge and at the same time ensure dissemination of uniform, high quality content all across the nation. Postgraduate students also form our primary workforce for providing patient care. This indeed is an important component of their training. We are aware that our postgraduate students devote a large component of their time for the patient care services and thus they have less time for self-study by the end of the day. The timing of this activity is therefore very carefully chosen. The sessions will be held late in the afternoon so that the beneficiaries do not have to make any extra effort for attending them. This by itself exudes the philosophy of a true teacher, a mentor that will handhold the children through the process of their active learning. As the sessions are online, which by its very design is a non-synchronous platform, it may seem that the delivery of the content will be one-sided, but enough measures have been planned and they are in place to make the activity as interactive as possible. The topic of the session will be shared with the students well in advance. This will allow them enough time to explore the subject and be better prepared to absorb the content. This design, therefore, also matches the concept and principles of adult learning. The program not only will help our postgraduate students in being better prepared for their examinations, but also will equip them with sufficient knowledge, understanding, and approach to be a better professional in their field. I wish this program all success. Thank you.
Yeah, so thank you for the message. So today, as we all know, and we all have that circulated mail, that today we are going to cover a very important topic, that is approach to systemic vasculitis, what a physician must know by a very eminent speaker for today, Professor Aman Sharma. Sir is currently professor at PGIMER Chandigarh, and he is also President-elect of Indian Rheumatology Association. He is member annual meeting planning committee, American College of Rheumatology. He is also expert reviewer of ACR Euler classification criteria of GPA, MPA, EZP, and TAK. He has numerous awards in his name. From API, he has Rabindranath Tagore Oration Award, VR Joshi, JAPI Award for Outstanding Referee, R. Subramaniam Endowment Oration, also Shurveer Trust Visiting Professorship. Sir has NIMAMS, NIH grant rounds on systemic vasculitis and relapsing polychondritis. Sir also has many recognitions from IRA, including IRA Oration, Jidus Oration, IRA Young Investigator Award. Sir has also eminent mild career rheumatologist Oration Award from CMC Vellore. He has more than 500 scientific papers and 66 book chapters. Sir is also founder of Indian Vasculitis Registry and Indian Relapsing Polychondritis Registry. Sir has written books on the few of them are textbook on systemic vasculitis, psoriatic arthritis, spondyloarthritis, tropical rheumatology, urgencies and emergencies in rheumatology, rheumatoid arthritis, ophthalmic science in practice of medicine. He also stands among top 2% Stanford researchers list. Sir is also convener of IRA guideline for management of ANCA associated vasculitis. With this brief introduction now, without wasting much of time, I would like to invite today's speaker, Professor Aman Sharma sir, for the talk on very, very important topic.
Good afternoon. I hope I am audible and my slides are visible.
Yes, sir. You are very much audible and the slide is pretty much visible with full screen. Thank you, sir.
Thank you. I think at the outset, I would like to thank Professor Behra and Professor Kapil for this very kind invitation and for interacting with the budding students across the country. It gives me an opportunity to speak on a topic which is very close to my heart. Why I have chosen this topic is, out of all the rheumatology topics, is that many times we believe that rheumatology in general and vasculitis in specific is not something which is discussed often in various postgraduate rounds or in the curricula of medicine postgraduate teaching. So I think in the next 45 minutes or so, I'll try to give a bird's eye view of what all physicians must know about systemic vasculitis. This topic is very vast. So I think in these 45 minutes, at least I'll give them a food for thought as to when they should consider the possibility of a given vasculitic condition, because these conditions, believe me, are not as uncommon as people believe. And there is a large burden of these diseases. Many a times, because of the delay in initial diagnosis, there are mortalities with these systemic diseases. With this, I would wish to start that as the name suggests, the vasculitis means vessel inflammation, which means the inflammation of the vessel wall. And as you can see in the cross section, the inflamed vessel wall can become thickened and leading on to occlusion or partial or near total occlusion of the blood vessel, leading on to ischemia of the organ or one organ or various organ systems simultaneously. So the other result which can be there is that if the inflammation has been there for quite some time, the vessel wall becomes inflamed and becomes weakened, and there is an aneurysmal dilatation of the blood vessel. So this leads to the rupture of these aneurysmally dilated vessels, which present with complications like diffuse alveolar hemorrhage, perinephric hematoma, retroperitoneal bleeds, aneurysmal bleeds in the brain, and various other organs. So it can not only cause ischemia, but the vessel inflammation can cause hemorrhage also. So these are the two key things which the residents should always remember. So the couple of things which are always talked about when people talk about vasculitis is classification criteria, nomenclature system. I would wish to say one thing, that there is no diagnostic criteria. All the criteria are either classification criteria or there are nomenclature system. Nomenclature system means that for naming a given disease or a definition of a given disease. Whereas a diagnostic criteria is one in which it not only makes a diagnosis of a given condition, but it excludes all other mimics of that condition also, which I believe, and all of us believe, that is beyond any criteria. So I think various efforts have been made over a period of time. These are some of the various lists which have been proposed from time to time. The older ones were the American College of Rheumatology criteria, Chapel Hill nomenclature system, the first one in 1993, and the revised one in 2012. There were criteria based upon pathology by Lai and Savage, and there was an algorithmic hierarchical approach called European Medical Agency System criteria, which were proposed in 2008. So this, if you look at how the things or the understanding has evolved on vasculitis over a period of time, this is a very beautiful picture which tries to simplify a big, a longish history, wherein on the left side, as you can see in this picture, I'm not able to use let me see if I can use some of the spotlight. So anyways, I think I'll stop it here. So you can see the upper half is clinical and pathological description. Below that is biological discovery, the Chapel Hill nomenclature system of 1993-94, and revised Chapel Hill nomenclature system. So this all started in the early 19th century, wherein Schonlein followed by Enoch, which was later known as Enoch Schonlein Purpura. Then there was description of vasculitis by William Osler. Then Zeke was the first lady. Paul Zeke, 1952, tried to classify it. And then Hans Klinger was the first person who described what was later known as vaginous granulomatosis and subsequently known as granulomatosis with polyangiitis. And Goldman and Churg in 1994 described Churg-Strauss syndrome. Then Kawasaki disease was described, and then there were various biomarkers. The most important biomarker that we are all aware is ANCA. It came to be associated with great deal of certainty towards the end of 80s that this is associated with small vessel vasculitis, what we now call as ANCA-associated vasculitis. And over a period of time, the other criteria which have been proposed are the ACR and EULAR criteria in 2022. So these are the ones that I put in red again. So after this, we, when we looked at the initial description of the criteria, we looked how these criteria are faring up in our group. We saw that when we applied various different criteria, EMEA system, into various different groups of vascular disorder of 79 patients, we saw that this gave, because this had incorporated ANCA into the classification system, so the unclassifiable, if you can see, 9% became 0. So that is how there was more refinement of the criteria over a period of time. Then came the American College of Rheumatology European League classification criteria. We had the opportunity to contribute patient data, and also I had the opportunity to be the expert reviewer and a co-author on these criteria which have been proposed. But I can tell you how these evolved, and this will give you a perspective of a disease, how the science or the things evolve, and then there are questions asked, and then the clarification sought over a period of time. So as you can see, that when these criteria were proposed, the first was a draft criteria. We in this criteria, there were various things proposed and a score of 5 was given. So basically there were clinical criteria, there were some tests, and then if there was a score of 5 or more, a diagnosis of GPA could be established. We applied this to our cohort of 187 patients of ANCA vasculitis, and if you look at it very carefully, this was not as chalk and cheese. There were still overlaps when we applied these criteria between GPA and MPA and eGPA. So subsequently, we said that weightage has been given to PR3, eye involvement and granuloma, but there is no weightage given to renal involvement, and I will allude to it later on that renal involvement is very important aspect as far as these ANCA vasculitides are concerned. So a revision was done for the basic data again, and kidney involvement was introduced into the draft criteria. There was no red or painful eyes in this criteria, and nasal polyps were given a score of -4 and were taken off. We validated this on a larger cohort, and we showed that perhaps still there were, in 222 patients, there were still overlaps which were persisting. Finally, this was the final criteria which has now been validated, endorsed by American College and European League, and has been provided here. But I can tell you there is a cartilaginous involvement here also. This is also a criteria which still needs to stand the test of time. Having said that, now I'll quickly change gears and now give you the examples when you should consider many of these clinical conditions in your day-to-day clinical practice. So I am taking the background of Chapel-Hill nomenclature system, wherein various types of vasculitis are divided based upon the vessel size, which means large vessel vasculitis, medium vessel vasculitis, or a small vessel vasculitis. Small vessel vasculitis is subdivided into ANCA and immune complex vasculitis. Or there can be variable vessel, which means there are diseases which can either involve the large, medium, or small. They are Behçet's disease and Cogan syndrome. We are also aware that vasculitis can be single organ or can be associated with systemic rheumatic diseases like SLE, rheumatoid arthritis, sarcoid, or relapsing polychondritis. And then there was a new category introduced, which was vasculitis with probabilityology, wherein we know that perhaps the hepatitis B viral infection is associated with polyarthritis nodosa, and then there is a causal association. Similar association has been proposed with hepatitis C associated cryoglobulinic vasculitis. And we are all aware about cocaine and levamisole associated, drug associated, ANCA associated vasculitis, and there can be cancer associated vasculitis also. So I'll start with the large vessel. So the first large vessel vasculitis is giant cell arteritis. So when does a physician or a resident think about large vessel vasculitis? So the couple of conditions are when an elderly patient comes to you with a recent onset severe headache, which is associated with jaw claudication or fever, and there can be carotid tenderness. So what you can do is you can put your hand on the superficial temporal artery. You can see in this picture, I'm sorry, I'm not able to use the pointer, but if you could see, there is a superficial temporal artery which is prominent. And if you put your finger just above the auricle and over the temporal area, if there is tenderness of the superficial temporal artery, or if there is a tenderness in the scalp area, then you should put your hand on the carotids and see if there is carotidynia. The next thing that you should do is ask for any visual impairment. And if it is there, then it is a very sinister sign. Many of these patients will actually be picked up by the ophthalmologist because of the vision loss. And then they will be sent to the physicians because of high ESR and high CRP. So the next best thing that you should do is send for ESR and CRP and do a Doppler of the superficial temporal artery. And if the ESR CRP is high, or if there is a vision loss, or if there is a RAPD, then I think we must institute the corticosteroids, and we should also try ultrasound. Doppler shows halo sign. We should not only ask for looking at the temporal arteries, but we can also ask for looking at the axillary arteries also from our radiology colleagues. You have to make a team actually, and it is a learning curve, and even the radiologists will take some time before becoming confident of how and when they are going to report that halo in the temporal artery. The other OPD procedure which can be done by surgeons is to take the superficial temporal artery biopsy. And if you see, if you look, draw your attention to where the arrows are, you can see the giant cells, and there is a break in the internal elastic lamina, which was shown in better way on elastin Van Giesen stain, which is not shown here. So, which is again, you may or may not see the giant cells, but if you have a break in the internal elastic lamina, then perhaps giant cell arteritis is the diagnosis. This was many 15 years ago when we had 7 people said that GCA doesn't occur in this country. This is the disease of the white world, but that is actually not true. Now we have seen around 100 patients. This is a very old data, more than 15 years data when we published along with our ophthalmology colleagues, the entire data from India along with 17 patients from our center. And many of them, they had visual impairment. The other important symptom that we had in half of our patients was jaw claudication. You should always remember this. And biopsy pickup rates have not been very great in our subset. But one has to remember that sometimes this giant cell arteritis can present without headache. And if you see large vessel vasculitis, there is a cranial GCA or large vessel GCA. These are the patients who will predominantly present either with fever, and the radiology done for fever will pick up either the thickening of the great vessels or uptake on PET scanning. Or rarely with low-grade fever with aneurysmal dilatation in the elderly. So these are the conditions where you should think about giant cell arteritis. The other large vessel vasculitis, which we are all aware, can be Takayasu arteritis, which is all listed here. We'll talk about it. This is the thickening and uptake in the branches of the arch of aorta in patients with giant cell arteritis, one of our own patients. I'll give you one very unique example. This was a patient admitted under neurology with reversible dementia, high ESR, abdominal aneurysm. There was very mild headache, there was shoulder, hip pain, and there was carotid which was tender. There was thickening of the superficial temporal artery, there was thickening of the brachiocephalic artery, but there was aneurysmal dilatation of the aorta. So this was, as you can see, 4.3 mm, more than 3 mm thickness, so which qualifies for the criteria of extracranial giant cell arteritis. So there are criteria based upon CT, and there are also criteria based upon PET where a diagnosis of giant cell arteritis, extracranial giant cell arteritis can be made. The most important thing is that you should be aware about this entity. Once you are aware, you think about it, you ask your colleagues in radiology or nuclear medicine, life becomes easier. I've seen patients where they've spent so much time and money going from one place to the other, and the diagnosis has simply been overlooked because the physicians were not aware about this diagnosis. And as I showed you, that patient was admitted with reversible dementia, and this is a Kelly's textbook of medicine, rheumatology, where reversible dementia actually is reported as one of the manifestations of giant cell arteritis, and abdominal aortic aneurysm is also reported, and especially in those patients who may not actually have classical headache. This is our own data. This is an old data. We haven't really updated it, but we've seen 25 patients with large vessel GCA, and you've seen these pictures already. The new phenotype, new kid on the block is whenever there is large vessel vasculitis or lapsing polychondritis in elderly males with cytopenia, with the textbook teaching or the bedside teaching is that whenever you think about inflammatory diseases, you have thrombocytosis, you have leukocytosis, you have ESR which is high, you have CRP which is high. Thrombocytopenia, leukopenia is against a diagnosis of vasculitis unless it is SLE associated, infection associated, or malignancy associated vasculitis. One new entity has been added to the list, which is known as Vexus syndrome. So this was an NEJM publication in October of 2020, wherein we have gone from phenotype to a genotype based approach. These were because of ubiquitin somatic mutation in UBA1, leading to vacuolation, E enzyme, it was X-linked autoinflammatory syndrome because of somatic mutation. These patients can present to various specialists. They can present to rheumatologists with RP, PAN, GCA, or SLE. They can present to hematologists with MDS type phenotype, with vacuoles in the marrow. They can present to dermatologists with neutrophil dermatosis, skin rashes, and these patients can have swelling around the eyes, and ILD kind of presentation also sometimes. So when do you suspect? When there is an elderly male, the most single investigation that you should always look for is MCV. If the MCV is more than 100 and there are cytopenias in a suspected giant cell arteritis or other relapsing polychondritis or other rheumatological diseases, think about Vexus syndrome. How do you diagnose? You look for UBA1 gene mutation, the facility for which we have established in PGI. The samples can be sent to PGI, and the treatment is actually very challenging. I have to give steroids, and it's beyond the domain of this lecture that we can treat ourselves as rheumatologists, and we may sometimes have to involve our hematology colleagues because they are more attuned to you treating MDS type of phenotype with azacitidine, and even if you have to do a bone marrow transplant in some of these patients. So these is a long list of clinical manifestations. Outside the NH cohort, the first patient to be diagnosed was at PGI Chandigarh with an SLE phenotype, an elderly male who was initially worked up at Delhi, but then presented to us with cytopenia, which was steroid responsive, and also some rashes and superficial venous thrombosis. Also, there were thrombocytopenia and leukopenia. And as you can see on top is MCV. Many of the MCV figures were more than 100, like 107, 104, 102. We did a marrow review which showed there were vacuoles. We sent this to David Beck and my friend Peter Grayson at the NIH, and this was in fact showed a ubiquitin gene mutation, UBA1 gene mutation, as you can see in December of 2020. It was the sample was sent at the same time when the NEJM paper. We had collaborated with the NIH people, and they in fact asked us if we have any suspicion of any patient, we can send samples, and we got the report after 4 weeks in the early December. So this was the first case diagnosed, perhaps diagnosed outside the NIH cohort, who had a lupus phenotype, because there was DNA positivity, there was hypocomplementemia, there was thrombocytopenia, which was steroid responsive. I'm not sure which was truly SLE, but this surely was an SLE phenotype. So the phenotype which was described by the NIH cohort was expanded by including SLE also amongst this. The other common large vessel vasculitis is Takayasu arteritis. They can present with fever, constitutional symptoms in a pre-pulseless stage. At that time, the PET will be helpful in diagnosing this disease. Or they can come with a pulseless disease, as we are all aware, and the symptoms depend upon what part of the circulation is involved. They can also have CNS symptoms, visual symptoms, stroke, etc. I'll give you an example. A young female came with fever, high ESR, echo-showed aortic root dilatation, and this was PET done in 2007 at PGI. It showed uptake in the aorta, and as you can see here, and a diagnosis of pre-pulseless Takayasu arteritis is made. Coming to medium vessel vasculitis, the signature disease is polyarteritis nodosa. I'll give you one example. A young male with dystonias or dystonic CP with a baclofen pump in, admitted under neurology with fever, had arthritis, dilated cardiomyopathy, high ESR and CRP, and as I said, thrombocytosis to the extent of 10 lakhs, 11 lakhs. We thought this could be polyarteritis nodosa. There were renal infarcts, and NCB showed up by nerve conduction. There was a neuropathy for which a nerve biopsy was done, which showed vasculitis. So we published our experience. As you can see, there is no blood test which is going to be positive. It's basically when there is a multi-system involvement, especially nervous system involvement, GI involvement, skin involvement, testicular pain. That's when you think about it. Hepatitis B can also be associated with polyarteritis nodosa. So there can be dominant neurological manifestation, as I said, mononeuritis multiplex, stroke. The one investigation which will come handy is CT angiogram, which can show microaneurysms, as can show here, or end organ changes in the form of splenic infarcts or renal infarcts, as you can see in the right-hand side picture. Another disease where India can take credit of sensitizing the world is the prevalence of a monogenic disease of deficiency of ADA2, which people believed is because of occurs in children, but we showed that it can occur well into adulthood. This is because of ADA2 gene mutation causing deficiency of ADA2. So you can diagnose either doing the ADA2 gene mutation analysis or ADA to enzymatic assays, or both, whatever, depending on what the facility is available. Before our paper, the median age was 4 years, but we showed that the patients can present well into the adulthood. This is our old paper published in 2020. We now have a more than 100 patient cohort, which I presented at Washington meeting last year. We've seen the patient now presenting for the first time as late as 58 years of age. And it is more common in Agarwal, Jain, Bania community, at least in North India. So one should always, they present with recurrent strokes, which can be both ischemic stroke or hemorrhagic strokes or both. We've also seen posterior reversible encephalopathy. This is the MR of the posterior reversible encephalopathy syndrome. There are organ infarcts like renal infarcts, pancreatic infarcts, splenic infarcts. There can be focal nodular hyperplasia. There can be vascular aneurysms. There can be peripheral artery aneurysms. This is a pancreatic microaneurysm and pancreatic infarct. This is a subacute intestinal obstruction. There are renal infarcts in these patients. You can see this very dramatic angiogram showing the studded with microaneurysm, not only the abdominal vessels, but if you could see even in the intercostal vessels also there are microaneurysms. So these are all, although it's a taught that PAN doesn't involve the lungs, but in data 2 we've seen a diffuse alveolar hemorrhage kind of presentation also in one of these patients. There is a severe GI involvement, and in fact GI involvement is a predictor of mortality in these patients. We can see there is an ulnar artery involvement. Biopsies can show both vasculitis and vasculopathy. Treatment, anti-TNFs are the only treatment actually, and most of the manifestations they improve once you start anti-TNF. This is what we showed. Before our data, it was shown that strokes don't recur, but we showed that most of the manifestations actually get better once you start anti-TNF therapy. Now coming to the another very important group, which is ANCA vasculitis. Whenever you have multi-system involvement of lung, kidney, skin, nerve, heart, think about ANCA. And the main three types are GPA, which was known as Wegener's, PGPA, which was previously known as Church-Strauss, and microscopic cholangitis. GPA has predominantly PR3 positive ANCA, whereas NPM has predominantly NPO ANCA. GPA has more of an ENT symptoms like nasal crusting, nasal bleed, nasal ulceration. EGPA has a nasal allergy and nasal polyposis, and there is history of asthma. Upper airway symptoms are not there in microscopic cholangitis. All of these can cause autoimmune glomerulonephritis. There can be monoitis multiplex, and there can be various skin lesions also. I'll show you the examples. There can be episcleritis in the eye. There can be very bad scleritis in the eye also. There can be grove rupture. There can be proptosis, as you can see in the left eye of this lady as compared to the right side. There can be oral ulceration, which can be on the tongue or in the buccal cavity. It is as if a pound of flesh. I'm sorry, this mark has shifted due to, I don't know why. There can be strawberry gums. You should always be looking for these in patients who present to you with soreness in the oral cavity. There can be nasal bridge collapse. In the middle picture, you can see the septum perforated in vaginas, nasal cavity uptake in PET scan in some of these patients. They can have sinus disease, very bad sinus disease. They can have subglottic stenosis. They can have various lung manifestations in the form of cavitating nodules with thick walls, pleural effusion, consolidation with air bronchogram, angiocentric nodules, mass-like lesions. Some of our patients have been previously labeled as having bronchogenic carcinoma. They can have diffuse alveolar hemorrhage, which classically spares the peripheries. This was a lady who presented in advanced stage of labor with cannonball opacities into the labor room. This was published in Lancet. This was actually, initially they thought this could be choriocarcinoma, but actually this was vaginous granulomatosis. We subsequently had 3 patients who presented with GPA during pregnancy, and we published a systematic review of pregnancy outcomes in ANCA also. Those of you are interested can look up that publication. There can be peripheral nerve involvement. There can be pseudotumor with proptosis. There can be pachymeningitis. This was the pachymeningitis with cranial neuropathies, which was unresponsive to corticosteroids. There can be skin lesions, which can be subtle nodule or a cutaneous infarct over the elbow, as you can see here. There can be this involvement around the inner canthus, which eventually became a very gory hole here. There can be pyoderma gangrenosum. This was patient referred as RA, but had a pyoderma and a red eye and was diagnosed to have vaginas. There can be necrotic hemorrhagic bully. There can be large pyoderma-like lesions. These are all data of 105 patients, which we collected more than a decade ago. Indian patients have less kidney involvement as compared to reported from the West. We have other publications also, but I don't have time. And most of the manifestations are same, except for the fact that Indians have relatively less common kidney involvement as compared to the West, and the same was the experience of Professor Ashok Kumar from All India Institute. When you treat, you have to be wary of the mimics. There is an induction phase followed by maintenance phase and then long-term follow-up. But these are interspersed with relapses, and I think whenever there is a relapse, one has to treat. Recently, we published data-driven Indian Rheumatology Association guidelines in autoimmunity reviews, a journal with an impact factor of more than 9. These were all data-driven. And this is a summary. So basically, the go-to drugs in a life-threatening disease are rituximab or IV cyclophosphamide, and relapse of GPA or MPA. And if the creatinine is more than 5.8, we can plex the patient. Plex has no role for DAH. And for maintenance, you have to use low-dose rituximab over azathioprine. And for eGPA, basically, if there is a major disease, IV cyclophosphamide or rituximab. And if there is a mild disease, then you can use mepolizumab or azathioprine or methotrexate. But the textbooks, the patients don't read the textbook. I taught you that if there is headache, vision loss, scalp tenderness, think about giant cell arthritis. Here was a young lady, a 55 years lady, who had all those with high ESR and decreased flow in the temporal artery. We did a temporal artery biopsy. That was normal. We did a temporal artery biopsy on the other side. There was a break in the internal elastic lamina. This black thread is the inner elastic lamina. There was a focal break, which qualifies for diagnosis of temporal arteritis. But the patient started to have foot drop, hearing loss, nasal symptoms, and ANCA positive. So this was actually ANCA vasculitis, because all those listed on the right side don't occur in giant cell arteritis. So this was a temporal arteritis because of ANCA-associated vasculitis. Kidney biopsy was done, which confirmed possible glomerulitis. In fact, we published this also in Arthritis in Rheumatology. Now, the other immune complex vasculitis is what was known as Henoch-Schönlein purpura and is now known as IgA vasculitis. Presents with palpable purpura, ankle arthritis, florid skin rash. Generally in children, self-limiting, but in adults, very severe GI involvement or severe renal involvement can occur. We almost 2 decades ago had seen 3 patients with severe mesenteric ischemia at IgA vasculitis. So, coming to variable vessel vasculitis, a young man with DVT with decreased vision. If you can see, there is a superficial thrombophlebitis, there are erythema nodosum, there are scrotal ulcers, there were oral ulcers, but there was decreased vision also, and there were posterior hypopnea. The other sinister manifestations are arterial involvement. We had various patients with aortic aneurysms, pulmonary artery aneurysms, dorsalis pedis artery aneurysms, femoral artery aneurysms. So we had seen 10 patients like that. And any of these, if they rupture, there is a very universal mortality. So I think this is the one that you need to consider. We can see the percutaneous interventions, the stents being put, the surgeries being done in some of our patients. So this can be single organ. This was patient who were labeled as IBD but presented with exsanguinated bleed. And the histopathology showed there was a granuloma sitting within the vessel, and there was so much fibrin. There was an isolated granulomatous GI vasculitis, which was falsely labeled as IBD. Vasculitis can be associated with various systemic diseases, as a review which we published many years ago. RA can have, all these can have eye, skin, lungs, nervous system, GI or kidney involvement. Sarcoid, can have what we call as necrotizing sarcoid granulomatosis, generally affects the lungs. Systemic sclerosis, actually the renal manifestation is, renal failure is what is called as scleroderma renal crisis. But what we have seen is all renal failure is not because of SRC, but we've at least seen 4 patients where the renal failure was because of ANCA vasculitis. So it is a good idea to send ANCA, PR3 or MPO in patients of scleroderma or systemic sclerosis who present with renal failure. Because unlike scleroderma renal crisis, which has very, very high mortality, this is treatable cause of renal failure in the presence of scleroderma. So you remember this, what I'm telling you. Sjogren's is a very common cause of various types of CNS and peripheral nervous system involvement, actually. And many of the obscure in mini CNS manifestations are either due to undiagnosed Sjogren's or Sjogren's associated with NMO spectrum disorders. Another disease which can have various manifestations is relapsing polychondritis. We have a special interest, and I'll show you a few examples. Idiopathic inflammatory myositis sometimes can be associated with GI vasculitis. We had a mortality yesterday because of a patient who was admitted as with inflammatory muscle disease outside, presented with GI bleed and had perforation. The surgeon took up, but actually she succumbed. She had presented way too down the road. This was a patient with sarcoidosis who presented with vision loss, but had optic disc edema. And if you could see towards the side, right-hand side, there are white rounded things over the disc, which are called as optic nerve granulomas. And if you see the white dots around the macula, this is called macular star. This was a biopsy-proven sarcoidosis presenting with optic disc edema. Initially, it was thought as malignant hypertension, but this was proven to be sarcoidosis, disc edema, treated with steroids, patient got better. This is relapsing polychondritis. You can see the on the right side, left side aortic wall is thickened. On the right side, if you could see, there is not only thickening, but intense uptake in the aorta. Towards the end, vasculitis can be associated with probability etiology, hepatitis B and C associated vasculitis. The immune complexes get deposited in the vessel wall, leading on to those balloons being formed of the vessel, weakened vessel wall, which form as microaneurysms, or there can be total occlusion of the vessel causing ischemia. There can be HCV associated cryoglobulic vasculitis, which can present with palpable purpura, painful skin lesions, GI renal involvement we've seen, form as microaneurysms, or there can be total occlusion of the vessel causing ischemia. In patient presenting with tumor-like mass and vasculitis, which can present with palpable purpura, painful skin lesions, GI involvement we've seen. Most important thing for making a diagnosis of vasculitis is think about it whenever any of these presentations that I've shown you, patient presenting with tumor-like mass and palpable purpura, painful skin lesions, we've seen. Thing for making a diagnosis of vasculitis is think about it whenever any of these presentations that I've shown you, patient like mass painful skin lesions, we've seen. For making a diagnosis of vasculitis is think about it whenever any of these presentations that I've shown you, patient like mass. Yeah, thank you very much for your patient hearing. I'll be happy to take up any questions.
Okay, thank you, sir. Thank you very much for the wonderful presentation. Sir, there is one question that already been posted and on YouTube by Dr. Jyoti. I would read out the question for you, sir. Thank you, sir, for the session. What are the situations in vasculitis where steroids alone are sufficient? Which are the conditions which require additional immunosuppressants?
Excellent question. Actually, the treatment decisions will basically depend upon what kind of vasculitis are we talking about and what is the extent of the disease. So, practically none would be treated with steroids alone, barring the fact that you have a very minor skin vasculitis for which you think that maybe might get away by giving short course of steroids for some time, which practically will be very hardly ever, because even in there we probably will wish to stop steroids or taper steroid faster and put something like azathioprine. So Not many conditions where you'll treat with steroid alone. Not many that I can think of, especially when we talk about systemic vasculitis.
Right, sir. Right, sir. Thank you, sir. There is another question by Dr. Vishal Gupta. Great session, sir. Sir, please discuss about infections mimics vasculitis. Thank you.
Excellent. So there can be the list of the, when we talk about vasculitis mimics, the talk has to be as much longer as we've had the talk today, if not more. But if I can tell you in quick time, one thing that you should always exclude is infective endocarditis, especially when you're talking about a pulmonary and renal involvement with skin signatures. A close mimic for multi-system involvement is of vasculitis, where even there can be autoantibody positives like PR3 or MPO or ANA is infective endocarditis. Other mimic is of, say, for example, TB is a close mimic of presentation with erythema nodosum and sometimes large vessel involvement also, especially around the lymph nodes. So for Takayasu, you can have abdominal lymphadenopathy with surrounding thickening of the and involvement of the aorta around those lymph nodes, or in the vicinity of periadenitis because of tubercular lymphadenitis, you should consider. We've had oral ulcerations over the glands and skin region and red eye and ankle arthritis because of tuberculosis, which was actually pseudo-Behçet's, which we published. The red eye was because of flectanular conjunctivitis. The oral ulcerations were because of the tuberclids over the glands. Actually, in Behçet's, you never have lesions over the glands. You have lesions of the scrotum or the penoscrotal junction. That patient, what made us believe that it is not Behçet's is that the lesions were over the glands, and there were skin lesions like erythema nodosum, and Mantu we did was 26 into 26. And then we sent the patient for eye examination. There was on slit lamp that there was a the surface was raised and it was a flectanular conjunctivitis. Although somebody has referred the patient to us for cyclophosphamide, thinking this is vasculitis, but that turned out to be TB. Then leprosy can have lepra reaction, and they can have Lucio phenomena. In Chandigarh area, we have less of leprosy, but in some parts of India, leprosy is still prevalent. So Lucio phenomena can very well mimic like vasculitis. Then then it depends upon what kind of a patient are we talking about. If there are aneurysms, sometimes there can be mycotic aneurysms because of infections. So you have to look at overall scenarios wherein we are talking about these.
Right, sir. Right, sir. Thank you, sir. Sir, there is another question. Someone from iPhone posted it. Is CT angiogram for abdominal aorta is necessary for the diagnosis of polyarteritis nodosa?
Well, actually, the thing is that you should always do a CT angiogram of the abdominal vessels. Why I'll tell you why. There was a patient who recently presented to us with what we call as cutaneous span. There were ulcerations. The cutaneous span has classically ulcerative skin lesions around the ankle with some satellite lesions around them. Those who have seen, once they've seen the picture, they will quickly diagnose that this is cutaneous span. Therein, you will treat only with steroid, with some azathioprine or some methotrexate. But as a protocol, we do CT angiogram of all those patients. And when we did the angiogram, incidentally, I had an OPD today and saw that patient from Bathinda on follow-up. There were microaneurysms in the kidney. So when there are microaneurysms, then the quantum of treatment and the choice of steroid-sparing drug that you use is very different. And you would have never picked this up, and the patient would have ended up coming with hemoperitoneum or perinephric hematoma, which would have been a life-threatening condition. But once you treat them, then the treatment is very gratifying. Many of those microaneurysms are going to disappear. You do a follow-up. So you can have two types of changes actually. One are vascular changes, which are in the form of vessel stenosis, ischemia leading on to, or microaneurysm in the kidneys, in the spleen, in the intercostal vessels. I've shown pictures of I think the students might have had those visual impression about how different and these are all our own pictures. And the other changes are microaneurysms are present only in 60 to 70% of patients. The other changes which are going to be there are splenic infarcts, renal infarcts in the absence of microaneurysm.
No.
Since there are no
हाँ जी कृष्ण जी
AIIMS
नमस्कार जी
going to come very handy. And the
Ravi
other,
ji, please unmute one who is speaking in
सर
between,
ਮਦਨ
please.
ਦੇ ਬੜੇ ਢਿੱਲੇ ਹੋ ਗਏ ਸੀ ਹਸਪਤਾਲ ਦਾਖਲ ਕਰਾਇਆ ਸੀਗਾ
Ravi ji, please mute them.
so the thing is that you should be very careful. This is a very important investigation. CT angiogram is easily available these days. I don't think there should be any problem because we must define the extent of the disease in the beginning. Because treatment options might be the quantum of treatment that you use. The other thing that you should always do is look for ADA2, TADA2. There's a huge chunk. India has the largest cohort. There are total 600 patients in the world, out of which 100 are in India. And it's a life-threatening condition.
Right, sir. Right, sir. Thank you, sir. Sir, there is another question from Dr. Anupama Behera. She wants to ask that can conjunctiva and parotid gland be involved in granulomatosis with polyangiitis?
Yes. Eye involvement is very common. I've shown you conjunctivitis, sometimes episcleritis, scleritis. Eye involvement has a large spectrum. Parotid involvement, yes. Sometimes they are actually labeled as Sjogren syndrome because initially they will have parotidomegaly, submandibular gland involvement, Sika symptoms. But when you test, they have other manifestations to suggest that this is actually not Sjogren's, but it is actually GPA. This is what I teach all my DM students. Because the quantum of treatment and the prognosis is very different between vaginals or GPA and Sjogren syndrome.
Right, sir. Right, sir. Thank you, sir. Sir, there is another question from Dr. Aditya Yadav. He is a trainee from GMC Kanpur, Haryana. Which sites are preferred for biopsy in most of the suspected cases of vasculitis?
Actually, it again depends upon what spectrum are we talking about. Let's go one by one. Takayasu and Takayasu, you are not going to do any biopsy from anywhere. Biopsy is not possible. By and large, skin involvement is not there, and you have aorta and its branches involved. You can't do a biopsy. Giant cell arteritis, superficial temporal artery is involved. So you do a biopsy from the superficial temporal artery. There's nowhere else from you can do a biopsy. Medium muscle vasculitis, actually, the only place from where you can do a biopsy is from the nerves. You do a nerve conduction. Sura nerve because sura multiplex is very common. You do a nerve conduction. If there is a nerve involvement, you do a nerve biopsy, document there is vasculitis. Or in unfortunate people who have severe GI involvement and they undergo laparotomy, those surgical specimens you should chase. Many times the appendix which has been removed, the gallbladder which has been removed are actually because of the vasculitis. So you should chase those specimens and ask your pathologist to do serial sections to see if there is evidence of vasculitis. So for example, I showed you somebody was labeled as IBD, and eventually when we asked our pathologist to review the biopsies which have been done outside, it showed there is an isolated granulomatous GI vasculitis. The other place from where you should always do a biopsy is a renal involvement in ANCA vasculitis. It shows post-immune crescentic glomerulonephritis. It not only diagnoses, it prognosticates because many of the patients will present to you with advanced creatinine of 8, 9, 10, 11. The patient is right in front of you. You don't know whether the patient is going to respond or not. Actually, there is a burden classification system, whether there is a focal, crescentic, mixed, or sclerotic. If it is all sclerotic, it is not going to respond. You may not go all guns blazing because you know that you will treat, but you will not go all guns blazing, and you can prognosticate. You already know if there is a longish disease, the cellular crescents become fibrotic crescents. You know, the opportunity is when the crescents are only cellular, actually, right? So it not only diagnoses, but prognosticates. Now the biopsy when there is a lung involvement. Say for example, if there is a tumor-like mass, or if there is a vaginus who you diagnosed previously comes to you with new lung shadows, and if there are signs to suggest other disease like sinus disease, lung involvement, RBCs in the urine because active sediments in the urine, are the markers of renal disease in ANCA vasculitis. But none of them are there, and there is only a lung shadow. Then in our country, we always think that either whether it is the basic disease or infection like TB or any other infection is now the only thing which has come on top of immunosuppression that we've used. So therein you should do a CT-guided lung biopsy or PET-guided lung biopsy. That is what we do all. Sometimes we've actually improved on Wegener's over a period of time. We've seen TB also in a couple of patients. So so as I told you, probably where we do biopsy depends which organ is involved and what are we looking for. Skin biopsy again, another important. Many times people make a diagnosis of systemic vasculitis based upon skin biopsy. But I can tell you skin biopsy may be associated with systemic vasculitis, but may not be associated with systemic vasculitis also. What we call as leukocytoclastic vasculitis in the skin, maybe because of drugs, maybe because of infections, and also maybe because of systemic disease. So you should remember this, that skin vasculitis may or may not mean systemic vasculitis. But if there are cutaneous infarcts, then we think it is basically a large, deep dermal vessel involved. It is more likely to be a systemic disease, not a palpable purpura kind of leukocytoclastic vasculitis.
Right. Thank you, sir. Sir, another question which is posted, sir, is there any clue to suspect PAN in early stage? Okay. So he basically wants to ask regarding the early indicators for polyarthritis nodosa diagnosis.
So PAN, when there is a fever, constitutional symptoms, somebody comes with weight loss of 4, 5, 6 kgs, you've done the initial fever workup. That's not contributing. Fever has been there 2, 3, 4 weeks. There is a ejection fraction which is also 40%, 50%, which is low. There is monoid, especially when there is early signs of neuropathy. None of the infections actually causes neuropathy, hardly any, barring leprosy and all that. So if there is that kind of a presentation, always think of polyarthritis nodosa. Then do a CT angiogram, and especially if you think infection, but the platelet count is 6 lakhs, 7 lakhs, platelet count gives you a very good clue. If the platelet count is more than 4 lakhs, ESR CRP is high, you ruled out infection, then inflammatory disease, especially vasculitis, has to be considered amongst the differential.
Right, sir. Thank you, sir. Sir, there is another question from Dr. Kani Revan. Any vasculitis with young hemorrhagic stroke, mostly parenchymal, have you seen, sir? Share your thoughts on it. Thank you.
Any with data to deficiency of ADA to polyarthritis nodosa, that's India's contribution to the world. In young patients, middle-aged patients, elderly patients, especially Agarwal Jain community with high ESR, high CRP, then strokes can occur with Takayasu arthritis.
Right, sir. Sir, next question is from Dr. Anupama Behra again. How common renal manifestations in HSP?
In children, less. In adults, yes, it can occur. Not very common, but it can occur. Once it occurs, sometimes it can be a nightmare. You do a kidney biopsy in those patients and treat aggressively with cyclophosphamide.
Right, sir. So next question is from Dr. Harsh. Anti-PR3 and anti-MPO ANCA4 prognostication in AAV causing RPRF. How often to repeat the assay, sir?
No need to repeat it again unless you are suspecting that whether it relapses occurred or not. So scheduled repeating, because serial measures don't really help clinically unless you are a researcher and looking at the finer things. For a clinical practice, practically never. Prognostication, yes, PR3 positive disease is more likely to have relapses, much higher chances of relapse in PR3 positive disease as compared to the MPO positive disease. And therapeutic condition, therapeutic decisions. If PR3 positive disease, especially relapsing disease is there, then in relapse you must use rituximab over cyclophosphamide. And you can read the Indian Rheumatology Association guidelines published in Autoimmunity Reviews in September, October last year to have more detailed information. Or get in touch with me, I'll send you those guidelines that we published.
Right, sir. Thank you, sir. These were the questions which were written in the chat box. I would request if anyone wants to ask any last minute question, they can raise their hand and we can allow them to unmute and then they can ask, or if there are no more questions, then we can proceed further. Okay. So there are no raised hands I could see, sir. Right. So that was an excellent session, sir, and the discussion was really amazing and was really fruitful to all the participants. So now I would like to request Professor Ajay Kumar Sood, sir. Sir is Deputy Secretary in the National Academy of Medical Sciences for the word of thanks. Over to you, sir.
Thank you so much, Dr. Jaswant. Indeed, it is my great privilege to thank the distinguished speaker for this evening, Professor Aman Sharma, sir. He has covered a very important topic in great details, especially sharing the experience from the clinical cases. So thank you so much, sir, for giving the practical tips to all of us, especially to our PG students, which are very, very useful. And we look forward for your support and blessing in future also. Thank you so much. I also take this opportunity to thank all the directors, dean, faculty member from various AIIMS, PGIMER, and all other medical institutions who have been associated with us. And it is your own program. So I again want to make an appeal to all the faculty members. Please give your suggestion how we can make this program better. And also you can share the topics of your interest and come forward to take this session. And for the PG students, we have nearly 1,500 students who have been registered for this program. So you can again communicate with your colleagues and you can increase the registration. Registration is free of cost. There is no money involved. And if you want to ask any question from the expert in future, kindly share your question with us. And we'll be happy to sort of share this question with the expert and that will be answered in the next. And we are also happy to share with the PG student that National Academy of Medical Sciences, in collaboration with Indian Council of Medical Research, has started online helpline for biostatistics for PG student. And the link we have already shared in the chat box. So those PG students who want to get guidance from the expert from NAMS as well as from ICMR, you can just register with that. Again, registration is free and you can have sort of book a slot and you can have interaction with the expert as per your time and convenience. Another information is related to another online certificate course which NAMS has in collaboration with IIIT Hyderabad. And this is basically for young students and faculty members who are technology savvy. It is artificial intelligence in health. And for the PG student, it is on a concessional rate of 15,000 rupees registration. And it is 12 weeks online program. And we have also shared in the chat box the details link. And you can, if you want to register for the next session, which is coming in May or June, so you can always do that. Another information is for a mid-conference of NAMS in collaboration with IIT Kanpur, which is being organized from 15th to 16th May. And the topic is again very interesting, how the biomedical is going to change the future health in our country. And so again, the details we have, brochure details we have shared in the chat box. So those who are interested, especially from Uttar Pradesh medical colleges, students and faculty members, they can register with that. So I will also like to thank all the PG students who have been with us and the participants who have made this session very, very interesting by asking questions. I would like to thank Dr. Jaswant, who has been helping us throughout for moderating this session. Thank you, Dr. Jaswant, for your support. And of course, our IT team, Mr. Ravi and Mr. Shivam, who has been writing to you, sending you the details of the program, and also ensuring that this program is being telecast on the Zoom. So those of you who have missed this program or want to see it again, you can always link to either go to the YouTube or you can also link to our website, which we have told NAMS website, and we have all the video recording of the previous as well as we'll put this video recording also. So once again, I thank you all for joining us. So thank you so much. Over to you, Dr. Jaswant.
Thank you, sir. Thank you very much. I would like to reply to one of the queries from Dr. Vishal Gupta, how to get notifications for next webinar. So you can mail us on NAMS, NAMS_ACA@yahoo.com. So like you will be added to our group so that we can send you the notifications for the regular webinars.
Another point is that they can register with us.
Right.
Shared with the link. You just free registration. So
Right.
once you register, we'll send you all the information, all the academic activities related to NAMS.
Right, sir. Thank you, sir. I would like to again thank you, Professor Aman Sharma, sir, for the amazing lecture. And it was enriching for all of us. Thank you, sir. So with your permission, we can call for the closure of the session.
Thank you very much for having me.
Thank you, sir.